Dr. John Polio is Associate Clinical Professor of Medicine, Division of Gastroenterology, University of Connecticut Health Center, attending gastroenterologist, St. Francis Hospital, and co-medical director of the liver transplantation service at the Hartford Hospital. He's here to talk about the abdominal examination. Welcome, Dr. Polio.
Thank you very much, Dr. Steiner. It's a pleasure to be here.
I wonder if you can help us know if the 15-degree angle of the abdomen or the purely flat abdomen is better for physical examination.
I don't really know the answer to that, to be honest. My preference is to keep the patient fully flat because I think that decreases any tenseness on the abdominal rectus muscles and enhances the exam. But I don't think that that area has been studied, at least not to my knowledge. And in my personal experience, it doesn't seem to make a huge difference, but I usually keep the patient as flat as I can during the exam.
And do you have any tips for helping to relax the abdominal musculature in the patient who seems unduly tense or where you're convinced there's something hiding under the abdominal wall waiting for your fingers to find?
Well, there's a few techniques that I think you can to use. One is distractibility, and there's a few ways to do that, but I find one of the best ways is just talking to the patient often about a topic that's unrelated to your specific exam. You're taking their mind off what you're doing, yet still being cognizant of what the patient's reactions are to your palpation. The second technique that helps is lifting the knees up. So the patient is in the supine position, and you flex at the hip with the knees off the bed, and that will decrease the abdominal muscular tenseness or tone and may enhance palpation.
On the rectal exam, one of the frustrations of all of us in practice is that it seems the younger the examiner, the less likelihood that they will do a rectal examination. And yet, when we read the write-ups by some house staff, the rectal examination description is confined to stating whether the stool tested positive or negative for fecal occult blood. Is there any other value to rectal examination?
Well, your point is well taken. I think the rectal exam is an important and often overlooked portion of the examination. And physicians don't do it for any one of a variety of reasons, including their own uncomfortableness with the exam and their perceived uncomfortableness of the patient, which usually is not the case. Patients will often be very cooperative with an exam if it's done in a respectful and careful manner. So I believe that the rectal exam is an integral part of the abdominal exam and should be used routinely.
Thank you so much. I'm looking forward to watching your abdominal exam.
Well, I'm looking forward to showing it to you. Thank you. This is our patient today, Mr. Taylor, who's consented to help me demonstrate to you the examination of the abdomen. Good morning.
Good morning.
Mr. Taylor, we're here today to demonstrate the physical examination of the abdomen, and there's a couple of important points that I'm going to make right off. And the first is that there should always be hand washing before and after a physical examination, and we're going to assume that that's already been done at this time. The second has to do with the patient, and it's important for me to make sure that you're in a comfortable position before we do the exam. Positioning of the patient in the abdominal exam is very important because that allows the patient to be cooperative with the exam and to help the examiner demonstrate the points that he or she needs to identify. The first thing is I'm going to have the head of your bed down a little bit. I'm going to adjust that for you. And you let me know if you're comfortable right here.
Oh, that's fine.
Okay. It's important to inquire about the patient's comfort. Some patients may have a mild kyphosis of the spine. They may require a pillow for support. Some patients may be short of breath, and you may not be able to lie them in the full supine position. You may have to make adjustments for that during the examination. The second part of the preparation is for me to drape you appropriately to give you privacy during the exam. And there should be a lower drape placed right below the pubis, and the upper drape can be placed right below the breasts. And this allows for adequate visualization for the examiner and provides some privacy for the patient. It's very helpful to look at the patient's abdomen from a set position. I choose to look at the abdomen from the foot of the bed. And it's also helpful to identify a light source to try to cast shadow on the abdomen, and that can point out different changes in contour or texture of the abdominal wall. What am I looking for? Well, I'm looking for changes in contour, abdominal masses or bulges, abdominal scars on the abdomen, change in the normal venous pattern of the abdomen, any change in the texture of the abdominal wall. Now, in Mr. Taylor's case, if I look from this portion of the bed, the abdominal wall seems relatively symmetric. He does have some scars. One that's clearly apparent is right here. It's a right subcostal scar, and that would be consistent with prior cholecystectomy. The abdominal quadrants, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Now, there's other ways to divide the abdomen, and the other typical way is into a number of different geographic areas. One is the epigastrium, which would be centered here, the right and the left hypochondrium, the umbilical region, which is in the region of the umbilicus up and down, and then the lower quadrants here. Well, we've inspected your abdomen, and we've seen that you've had scars from prior surgical procedures. But otherwise, your abdomen is relatively symmetric. I'm not seeing any distortion of the abdomen. I'm not seeing any unusual masses or bulges that would call my attention later as part of the auscultatory or palpation part of the examination. Okay, well, I'm just going to examine your abdomen with my stethoscope. Okay. Now I'm listening in all the different quadrants of the abdomen, the quadrants that we just reviewed, and I'm listening for an adequate amount of time to ensure me that I'm getting a good representation of what the bowel sounds are. Sometimes you may need to listen for a much longer period of time, especially in a situation where you're suspecting an ileus. Next, I'm going to listen for bruits. In regions looking for renal artery bruits. And over the femoral arteries. And I don't appreciate any bruits in this particular case. Now, there are a couple of other inspection portions of the examination that I'm going to point out very briefly now. One is around the umbilicus. You can often see hemorrhagic changes there, a so-called Cullen sign, and also in the flanks, a so-called Gray-Turner sign. Now, on palpation, there's a couple of ways to palpate, but I find that this portion of the finger is the most sensitive. And I think if you start with gentle, light palpation first, and then progress to deeper palpation, you'll be more comfortable. And if you're more comfortable, I'm going to have a better exam. So again, I usually try to focus in an area that is not the focus of the patient's complaint, and I just gradually palpate across your abdomen. If you have any discomfort, let me know. No. It's also helpful to talk to the patient during the exam, often about something that's unrelated to the examination. That distracts the patient and again enhances your ability to get a more appropriate exam. Mr. Taylor, do you work?
I do, yeah.
What do you do for work?
I'm retired. I work part-time.
Where is that?
I'm a massage therapist.
Oh. How am I doing?
You're doing fine. You're doing fine.
Maybe we should switch positions. Well, I've gently palpated the abdomen, and I'm not feeling anything of concern. But again, this is relatively light, superficial palpation. And I'm going to now press a little deeper. Now, when I press deeper, I use my opposite hand to press down on my examining hand. So again, I'm palpating lightly, but now I'm going to press a little deeper. Okay? And I move my hand back and forth, trying to mobilize the organs underneath the abdominal musculature. If I cause you any discomfort, just let me know.
Okay.
What am I focusing on? I'm focusing on the presence of any masses, any asymmetry in the abdomen. I'm looking for signs of tenderness or vocalization of tenderness from you.
No, nothing.
I'm going to palpate the femoral artery. I'm going to palpate for any evidence of lymphadenopathy or for hernia. There's some specific maneuvers for hernias that we can go over later if we need to. I'm going to palpate the umbilicus. Now, there's often tenderness over the aorta. It's a non-specific finding. It's very typical. Now, as part of the physical exam, there's a focus on solid organs in the abdomen and retroperitoneum. And I'm going to demonstrate those now. They're demonstrated in my mind best by a combination of palpation and percussion. It's also important to be able to quantify or quantitate the size of these organs, and that's especially important in terms of serial examination. And there's a couple of ways to do that. One is to carry a tape ruler with you or a tape measure, and the other is to measure your own body parts. And that way you always have your ruler with you. You never have to worry about carrying it, and that's what I do. So I've measured my palm, actually fingers, and from my pinky finger to my index finger is 8 centimeters. So I know that when I percuss or palpate an abnormality, if I put my hand flat on the abdomen, that's 8 centimeters. And then I can modify that based on the size of the structure that I'm examining. So I never carry a ruler anymore. I just carry my fingers. So with percussion of the liver, you start over the lung. You'll get a resonant sound and a tactile sensation. As you go over the liver, it obviously becomes dull. And then as you go over the air-filled viscus in the abdomen, it becomes a more hollow sound again. I think the upper margin of the liver is best ascertained by percussion. And that's what I'm going to do right now. I percuss using the third finger on my right hand and the third finger on my left hand. And it's just a gentle motion, kind of a rapping sound like that. And I'm hollow here. And right here, I get dullness. So that's the upper margin of your liver. So I'm just going to put a little pen mark right here, a temporary tattoo. That'll come off after the exam. And then I percuss upwards. And again, right here, I get to a dull area. Now that's right in the area of the rib cage. I think the best way to ascertain the lower margin of the liver is by palpation. And so, again, I use this portion of my finger. There's a couple of techniques. You can go upward like this, or you can place your fingers underneath the liver margin like this. I prefer that technique. You just have to use each technique and come up with one that you find it works best for you. And then what I'm going to ask you to do, Mr. Taylor, is take a slow, deep breath in when I ask you to. Breath in, out, and I'm just starting to feel the liver edge on the end of deep inspiration. Again, out. Now, I'm going to make a mark here. So I'm going to go from there to the lower mark that I've placed. I'm going to use my fingertip ruler, and I have a liver span of 8 centimeters, and that's a normal span. So I consider a normal span of liver up to 10 centimeters. Beyond that point, you have to think that the liver is enlarged, and that's hepatomegaly. Some patients, or some physicians I should say, just talk about the lower margin, and they'll say 2 centimeters, 6 centimeters below the right costal margin. That doesn't tell me anything. That doesn't tell me the total span. It's certainly suggestive that the liver may be enlarged, but it also may be a result of the diaphragms being flattened with, let's say, chronic obstructive lung disease. And in fact, the total liver span is normal, even though a larger portion of it is below the right rib cage. When you're percussing and palpating the liver, it's also important to get some idea of the texture of the liver. Is the edge firm? Is it sharp? Is it nodular? Is it pulsatile? Is it tender? And those different characteristics can point to specific conditions of the liver. Mr. Taylor's liver edge is firm, it's smooth, there's nothing about it that would suggest pathology to me. Next aspect of palpation of the solid organs of the abdomen is the spleen. And there's a couple of ways to palpate the spleen and percuss the spleen. I think palpation works best with the spleen. The spleen is on your left side, underneath the left rib cage, left upper quadrant. I'm going to demonstrate the technique that I find the best, and then a couple of other options that you have. Mr. Taylor, I'm going to ask you to roll. That's good. I'm going to keep your knees bent up a little bit. That decreases tension on the abdominal wall. I'm going to place this arm behind your back. And then I'm going to press on your back forward to me with my left hand. And I'm going to use my right examining hand. Again, I use this portion of my fingers. I think that's most sensitive. And I place that right here underneath the left costal margin. I'm going to ask you to take a deep breath in. And I'm just trying to palpate the edge of the spleen out. Again. Out. That's normal. Just be normal. Thank you. So that's one technique. Second technique is to place your fingers underneath the rib cage like this, either in the right lateral decubitus position that Mr. Taylor is in now, or in the supine position. And again, Mr. Taylor, I'm going to take a deep breath in, out, again, out, again, out, and that's normal. The other technique is percussion, and I'm percussing right at the left costal margin. It's a hollow sound. I'm going to ask Mr. Taylor now, as I'm percussing, to take a deep breath in, stays hollow, out. Thank you. If there was splenomegaly, as the left diaphragm is displaced downward with inspiration, the spleen comes down below the left costal margin, and that hollow sound becomes a more resonant or solid sound. I'm going to have you go right back onto your back. Now, you can also palpate the kidneys in some patients. I personally have not found this to be particularly helpful, other than in patients who have massive massive enlargement of the kidneys, often with polycystic disease. Now, one of the other important things I think to focus on is there anything else in the abdomen that doesn't belong there, namely fluid, ascites. And there's a number of techniques that we can use for that. I'm going to demonstrate what I think is the most helpful for me, and that's with percussion. And again, I percuss on the abdomen, and I move from the region of the umbilicus to the flanks, and I'm looking for a change in resonance, dullness to percussion, and I put a mark. Again, I'm going to give you a little mark here. Where I lose that resonance to percussion. And now I'm going to ask you to roll back on your right side toward me again. And this is what's called fluid shift or shifting dullness. And I'm going to move you back just a little bit, Mr. Taylor. Thank you. Again, I'm going to start. And I'm going to get back to where I was. What I'm looking for is a change where I lose resonance. I'm going to have you roll all the way back onto your back now. I already have my mark there. And I'm pretty much right back to where my mark was. Well, we focus primarily on the abdomen, but there are a few important things to focus on as part of the abdominal exam, which really are not part of the abdomen itself. And one of those is the presence of lymphadenopathy. It's important to feel, I think, particularly in the supraclavicular areas, on the left side for lymph node enlargement there. That's the drainage of the upper lymphatics, and you can often see lymph node enlargement in the presence of distal esophageal or gastric carcinoma. And we'll demonstrate that right now. We have two supraclavicular fossa, so it's helpful to compare one to the other. And I'm just palpating, Mr. Taylor, for any lymphadenopathy, and that area is normal. I think the second part of the examination that's important from a gastroenterologist and hepatologist viewpoint are cutaneous findings and extremity findings. I look for coloration changes such as jaundice, the presence of cutaneous manifestations of chronic liver disease. That would include spider angiomata, pulmonary erythema, clubbing, which you may also see in patients with Crohn's disease or celiac disease, edema of the extremities, the swelling of the extremities, perioral telangiectasia, which may be a manifestation of Osler-Weber-Rondeau syndrome. So there are a variety of cutaneous manifestations that one should look for as part of the general exam, and those can often be done very quickly at the time you're seeing the patient initially as you're initiating the examination. I'm just going to cover you up here, Mr. Taylor. The other portion of the abdominal exam, which is often neglected, is the rectal exam. And I think that's an important portion of the exam. Obviously, in directed circumstances, the rectal exam, I think, should be done in the assessment of most patients who present with abdominal symptomatology. Again, the exam is divided into inspection and palpation. You're going to expect the perianal region, looking for fistula tracts, hemorrhoids, masses, signs of inflammatory activity. The digital exam is important. The prostate is palpated in the male. It's important to palpate for tenderness in different quadrants and to palpate for masses. The examination of the abdomen can be quite involved. It entails not only examining the abdomen itself, but also some peripheral areas that may give you a clue in terms of what's going on in a patient who presents with abdominal symptoms. Thank you.